Friday is our bonfire. Which is actually one of my favorite social events we do. We go to Dockweiler Beach, we have a bonfire, have s'mores, play with football and stuff. So it's a really good time. I hope as many people as can make it as possible. And we'll have a carpool sign up in the Facebook group for that. So thank you. And without further ado, Dr. Donald Nikchevich.
I thought I was going to get a whole half hour of listening to you. This is good.
Okay. No, not that slow.
Okay. Let's see. How's everybody doing today? And let me put some glasses on and play with this machinery that didn't used to exist. When I went to dental school here at USC, we actually had slides. They're these little 35mm things that go on a carousel that spins around. And we didn't have all this fancy stuff. But now we've got fancy stuff. Fancy stuff coming up. Let's see.
It takes a little bit.
Is it on?
It should.
Yeah, it'll take a little bit. No, I don't see it. Hold on. I had it on earlier. Muting. There's PC. There's on. Let's see. There it is.
Same noise.
Yeah, it's like you see the blue light. Okay.
Well,
It went to sleep. All right. So today, this is my second time here, and my first time was a lot of fun. You guys were a very receptive group and a lot of interesting people that I got a chance to meet. This time what we're going to do is we're going to talk about some of the stuff that we see on TV. And how many people here have parents that are dentists? Okay, so then you hear a little bit about this stuff. Okay. And let's see whenever this goes on. Okay, can you turn that light off for me?
Yeah.
Or is that, here, lights. Lights, scene 1, scene 2, scene 3.
There, I think that one. No? There you go.
I can do all off. Oh, there we go. Now we're talking. Okay. Perfect. So, so the last time I was here, as I said, it was I sort of did an overview of oral surgery and gave you an idea of what we do as oral surgeons. And let's go through here and I'll show you a little of my office. Today we'll talk about my practice again, for those of you that didn't see it, just so you understand who's there and where we're at. We're going to talk about education versus an educator, which is just sort of an interesting difference there. And the main topic for today is going to be how do they advertise teeth in a day? You know, if you listen to the radio, you'll hear Dr. Goldfuss or Cunning Dental or Clear Choice, who's the #1 doer of all this. And we're going to talk sort of about this model a little bit. And what I hope it does is gives you just an idea of some other aspects of dentistry that are sort of coming down the pipe, okay? Didn't exist a while ago, but I'm going to give you a little history that will probably give you more information than 99% of the dental students that graduate from here, because a lot of this gets lost in history. We sort of just sweep it under the rug kind of thing. So we'll see what we've got. This is me. I'm the guy with the loops on. The guy with the white shirt back to you is Nick. For the last 3 summers, he's assisted me. I have 29 ladies that work for me at my office. And of my surgical assistants during the summertime, I get the pleasure of having Nick help me out. So it's a lot of fun. And that's Tammy, who's back, you see there. So we get, the ladies all love having Nick around too, because he's young and I'm old. So that's great. I am a board-certified oral and maxillofacial surgeon. I went to Keck School of Medicine to do my residency. I attended Ostro School of Dentistry. Neither of them was called that when I went here, but I guess you get new things and they give you the new names. It was the Norris School of Dentistry, and I don't remember what the medical school was called, but it wasn't Keck at the time. But all my new stuff says Keck on that. And I went to USC undergrad. And I went to USC undergrad when it cost me $52 a unit to go to USC. So I'm sure you guys are not paying that anymore. But anyway, and you used to be able to drive all over here because there was like houses on this block right here. So it was a long time ago. This is my partners. And I have one new associate who's a good friend of yours who on next Tuesday we're taking our new group picture. And the next guy here will be Jonathan Shoddy. John graduated from USC about 5 years ago, and he did his oral surgery up at Fresno, and he finished that 4 years ago, and he's been with me a year. Greatest guy in the world, literally unbelievable, hard worker and great surgeon. Mike Newton, he's my, well, let's start with the senior partner. Old guy with the gray hair is Scott Benyon. Scott's an MD, DDS. He did his undergrad at Utah, dental school at UOP, oral surgery at Vanderbilt. Did his med school at Vanderbilt, and he did craniofacial surgery at Harvard. where he was an instructor at Harvard, and then he came out and joined our practice in '81. Next guy in line is me, and you know about me, so I'm on that side. And then came Mike Newton. Mike was a UCI anteater undergrad. He went to Loma Linda Dental School, although he drinks and does all sorts of crazy things. He eats a lot of meat, so I don't know how he got in there. USC Oral Surgery, USC Med School. And then the shorter guy in the middle is Wayne. Wayne was actually my classmate. We finished 1, 2, 3, 4 in our class, my wife, Wayne, and myself, at USC Dental School. Wayne went on to Pittsburgh to do his oral surgery, and then he went on to do medical school at University of Pittsburgh. Then he did general surgery at Pittsburgh, plastic surgery at Michigan, and craniofacial surgery at UCLA. And now he is the chief of pediatric plastic surgery and craniofacial surgery at UCLA. So when he got the job, we couldn't tell him not to take the job because one of his mentors, Henry Kawamoto, had retired and they couldn't find a replacement. And so they came to him and said, will you do it? And prior to working with me, he was the head of craniofacial surgery at University of Oregon for 7 years. So these guys are all guys that went to school a long time, okay? And do you need to do that to have fun in dentistry? The answer is no. I mean, if I was a GP, just having gone for 4 years of dental school, I'd still have a great time doing dentistry, okay? Just happened to be a direction that we all headed in. So I think Wayne probably did 22 years. If you guys ever run into Mark Urata, does anybody know Mark Urata? No? Okay, Mark is the head of plastic surgery at USC School of Medicine. He's also the head of oral surgery at USC School of Dentistry. He's also the head of craniofacial surgery at Children's Hospital. Mark was a classmate of mine. He was a year behind me, and he was my junior resident. But I think by the time he started USC undergrad and was a band member, and the time he finished craniofacial surgery at UCLA, he went 24 years. So I just want you to understand that this isn't a so when you're complaining about your 4 years now, you know, there is the potential that somebody in the audience, you know, will be talking about, will have gone a long time, okay? So anyway. That's that. This is our ICAT machine and some of our operating rooms, and we have big, little operating rooms, 3 of those. Big operating rooms, 2 of those. They're like hospital kind of stuff because we do sort of hospital kind of surgery. So that's just the way it works. The one thing I wanted to mention here is as you're finishing up or starting up or wherever you are at USC, you're here to get an education, and your education is fantastic. I mean, this is a really good school. It's actually much harder to get into than when I went here. I probably wouldn't have even gotten in here. So you guys, congratulations to you. But try to find out from your best professor, or the person that influences you the most in lectures, how are they an educator that makes you like them? Okay, what makes you like that class so much that you sit there and go, man, that's my favorite class. Okay, why is that important? Because when you get into dentistry, and you get into oral surgery or endo, probably not endo, everybody's in pain in endo, so they're just happy to see you. But anything where they're gonna be spending money on something you're doing, the better educator that you become, the better you will be at being a dentist, being an oral surgeon, being an endodontist, a periodontist. It just goes without saying. There are about 360 dentists that refer into my office, so I get to see a lot of dentists. Okay, some of them are in my area out in Westlake Village, some of them are all over the place. And the bottom line is the patients that come in that are better educated by their dental team that we have are just much more receptive to treatment and to accepting treatment and doing everything else. So, you know, find those little niches, those little things. I had a couple people that I watched, you know, and I'd sit in class and go, why do I like this class so much? You know, and there were some little nuances on things they did. And that actually translates in how you talk to a patient when they're just sitting in front of you. So just pick up those things, and you know, you're here now with a great set of professors in undergrad. So you know, learn as much as you can, and then hopefully you'll all get into a dental school if you so desire, and go from there. So today, are you familiar with Novum? If anybody's familiar with Novum, you're lying. I think there's 30 people in the world that are familiar with that. Teeth in an hour, you might be familiar with. Teeth in a day, you might be familiar with. And all on 4. So anybody who has parents that are in dentistry might say, oh yeah, I have this all on 4 case. Well, my goal is today is to get you guys to understand what has happened with this over time that's got us from here, which was sucky failure, there, which was a almost worse sucky failure, to here, which is actually good. Okay? So that's what we're going to cover. This is Grandma, and I'm using some Noble Biocare slides because that way I don't have to put trademarks all over them. Noble Biocare is a Swedish company. They're inventors of dental implants. So if you went and said, well, who made dental implants? We're going to find find out in a second. That's Dr. Brandmark. He was the inventor of them. And what we're going to talk about is the old-fashioned denture over there that has no teeth, and how can we make that into somebody that has fixed teeth that don't come in and out, that you don't have to use polygrip on. Okay? So the options are to have a denture that comes in and out that snaps onto two little ball attachments, or we can have a denture that comes in and out, so like grandma's denture that sits in a cup that fits on a fancy bar with some little snap attachments. We call these little guys locator abutments. Or we can have a denture that is now fixed. It's actually usually a titanium or gold base. That's the one over there that sits on top of implants, or the bottom one sits on something called a multi-unit abutment. It's just an abutment that interfaces between our fixed implant and the restoration. Those two on your right side do not come in and out of the mouth. The two on your left side do. But that lower right one is sort of the buzzword right now in dentistry. So here's the history. Dr. Per Ingar Brandmark is the inventor of osseointegration. He passed away last year in 2014 at 84 years old. Okay, did a huge amount for us in dentistry. I mean, if you had a guy that revolutionized dentistry, that's the guy right there. He was an orthopedic surgeon. He wasn't even a dentist. Okay, so there you have it. You're like, okay, did that guy revolutionize? He was doing studies. They say nicely on rabbits, but they were actually on beagle dogs. Everybody knows what a beagle is, right? But he used to lecture, and I'd listen to him for hours, and I go, what the hell is he talking about? He'd call it beagle digs. And I go, what is a beagle dig? And it's beagle dogs. So what they would do is they took, for orthopedic surgery, they were looking at the femurs of beagles. They had something called a titanium tube. It was a titanium with a glass rod in it. They'd implanted into the femur of the dog, and every month they'd bring the dog in, they'd look at it under a microscope and see how bone grew. And this was in the early 60s that he did this. When he was done with the experiment, they tried to take the titanium out and they couldn't remove it. So then they got smart and they said, well, why is this stuff stuck in here? We didn't drill it in, it doesn't have anything on it, it's just pressed in there. And they came up with something called osseointegration. Osseointegration is what dental implants function on. That is, the bone adheres to the implant. And I'll show you a little bit of stuff on that in a second, and we'll talk about it. Okay. Next was 1982 was the first Brandmark, that's what they called it at the time, course on dental implants in the Northern Hemisphere. It was in Toronto and then followed up in New York. I always wondered why I would go to meetings in 86 and 87. I'd be going, I'm doing all the stuff that these legendary guys are doing. Why is that? Well, it was because I didn't realize at the time, I was so dumb that I didn't realize it all started in 82. So I was sort of right there at the beginning of all of it. And it's that time where it started in the United States. In 2000, they introduced something called Novum, and we're going to talk about that. We have all on 4 at the bottom. Novum was all on 3, and it was only, we'll discuss it, and then teeth in an hour, and then the all on 4. So that's what we're going to look at. So here's a great picture, propaganda from Noble Biocare, Swedish company, biggest implant company in the world. Right side, you see an implant. Left side, you see the root of a tooth, and we have that bone touching there. What they found out was they called it osseointegration because they felt the bone was gluing itself to the titanium. It actually didn't work that way. It's just all they had was light microscopes. And so when they came out with the electron microscope, and one of my patients actually invented the atomic microscope, they were able to look at that interface and they said, here is bone, here's a space, and here's titanium. What's in the space? The space is titanium oxide. So if you had a really cool titanium bicycle, and you left it out in the rain, it would not rust. It would look really cool. If you had a cast iron bicycle and you left it in the rain, it would be all rusty. So titanium does not rust very well. It has like an 8 to 20 angstrom theory of rust on it, and that's what the bone sticks to. So the bone actually adheres to the rust layer on the titanium. Don't tell your patients that. That doesn't sound good. That's what's happening. And so here we see that it looks like a tooth, feels like a tooth. And I've placed over 13,000 implants now, so that's sort of a lot. And so I sort of know what I'm doing on a good day. And bottom line is that at this point in time, if somebody's missing a front tooth, we can replace it totally so that nobody knows it's missing. And I have wonderful, beautiful, 18, 19, 20-year-old young ladies who are missing both their lateral incisors that whenever I see them, nobody knows that those teeth never came in. They were born without them, and now they look fantastic, and it's just like they had them their whole life. So that's what we're looking at. So that's Dr. Brandmark, what he gave us, and here is Novum. Now I did an internet search, and I could find like 8 things on Novum. That's how well they hid it, okay? So I actually went to the very first Novum course. There was 15 doctors from across the United States. That was it. They invited 15 people. It was in, what's it called, La Costa, somewhere down in the south. Where's the, we do the tennis stuff? Yeah, whatever. By Miramar, down in that, like, down in San Diego. And they introduced this thing. Basically, it was, we're going to put in 3 implants on somebody's lower jaw, only on their mandible, and they have to have no teeth at all, no teeth to start with. We're going to put one in the middle, and we're going to put one here, and we're going to do it, at the day we do it, we're going to give them teeth. They're leaving with teeth, teeth that they can chomp on, they can eat whatever they want, they're functioning, they got teeth. Now, this is before computers and everything. I mean, computers were there, but they didn't do all the cool stuff they do now. So what you had to do was install this jig in their mouth. So you put this, do a couple holes, install this metal jig, grind things down, drill through the jig, and that would make everything parallel. And then they came up with, there was 5 jaw shapes. And of those 5 jaw shapes, you would choose ahead of time what you thought the patient had and build their teeth on it. And then you'd put that in there and you'd be ready to go with that, okay? So that was the thought on Novum. I went there and I said, you know, really, they said, about 15% of the population missing teeth is a candidate. So if you have 100% people missing teeth, only 15% of those could even have this done. But this is the original, I'm going to load them up kind of thing with teeth. Now, so it's all on 3 implants, prefabricated teeth, done ahead of time. So the day the 3 implants are put in, these prefabricated teeth go in. Had a special implant that you couldn't buy today if you wanted to. I was trying to even find one. I couldn't even find one anywhere. Only on the mandible. And only possible on 15% of the population. So that was it. So if anybody ever quizzed you and said, gee, I do all on 4s, you say, do you remember Novum? And if they say no, then it's like, okay, well, why not? You should at least know that if you're old like me, because that was around back then. We got better computers, everything got faster, everything got better, and we started getting into Nobel Guide. Again, proprietary for Nobel Biocare, the big Swedish company. Nobel Guide is that thing over there. That's actually a prefabricated guide that's milled by a computer, and it's designed on where you're going to place the implants. So you take a 3D image, and we talked about those last time about 3D CT scanning and everything. You go onto the software, you design where you're going to put the teeth, where you're going to place the implants, and that guide, you drill right through it. So it's a reduced surgery time, custom precision drill guide, less invasive. There's the thing, often less than an hour. So thus, the teeth in an hour. Okay, if you think that anybody can go anywhere and get teeth in their mouth in an hour, there's no way in the world. I mean, really, even with this, as they say, teeth in an hour, you're looking at a 6-8 hour appointment in the hands of most people. If you've done thousands of them, you can get it down to 3 hours or something. But the teeth in an hour was, I don't know what they were thinking. I mean, that was just sort of an interesting thing. But that's how they sold it. And that's something that we saw in the 2003-2005 time frame. So definitely based on models, and the computer was the key to that. And this goes to show you where we're headed. You see that milling machine, milling that piece of titanium on the right-hand side. Basically everything is heading in that direction. And by the time you guys are done with dental school, there is no doubt in my mind that you'll have 99% of your stuff milled in the office. You'll be very computer savvy, which you're going to need to be. There's good interfaces, but you still got to know how to fix the little bugs that come in computers. But everything is just milled amazingly well at this point in time. So how does it work? Basically what we have is we've got you looking in the person's mouth on the left side and making a diagnosis. And then what we've got is looking at the top there, there's a computer-based planning versus the old-fashioned manual if you get models and planning it. And then you come up with a guide, either via the computer or via manual. And then you either make a temporary or go to the final restoration. And again, the final restoration doesn't usually happen right away. Okay, so everything that you see advertised, and your patients will come in and they'll say, well, I saw on TV, Don, that you get teeth the same day. I'll show you how you get teeth the same day, but you're really not getting your final super duper set of teeth the same day. Okay? There are some ways to do that, but that's really not the mainstream. So how does it work, for example? Conventional approach, planning, meet the patient, see what their problem is, reflect the flap, put the implants in, let them heal, remove the stitches, remove the healing abutments, abutment installation, make a provisional, make a final impression, try it in, deliver it. A lot of appointments there. That's probably about 4 or 5 appointments. This over here, planning, implant placement, Provisional, they say optional. Again, they're really pushing this. They like to push their stuff. And then the final restoration. So that's usually planning. That's one visit. Surgery is one visit. Usually there's like 4 post-op visits after that. So they're quick little checks and stuff. And then when it gets to the fabrication, usually that's about another 3 or 4 visits. Okay, so the reality is that you're looking at 8 or 9 visits even with teeth in a day. Okay, nothing just happens miraculously like that. But we'll show you some cases. So the prosthetic options, we've got teeth in an hour. Laboratory builds an acrylic framework, and the laboratory offers Procera is their proprietary name for a titanium bridge that's made on a milling machine, basically. And then the provisional prosthesis using permanent or temporary abutments, and I'll show you pictures of those because that's sort of hard to tell. So with teeth in an hour, which was our second thing, remember we had Novum first of all, which was not real good, and then teeth in an hour, which is this is the best thing in the world. That thing, that guided abutment, okay, again, try to find one of those now. You know, that was only 2005, it was 10 years ago. So I mean, most of you guys were like in middle school, right? No? Somewhere around there? So it wasn't that long ago. Guided abutment is like a squishy thing. You can see that it's got like a flare thing. So what it was doing was they were saying, we can get the implants in the right place, we can make these teeth ahead of time, but we can't get them perfect, so we're going to give you this little sloppy abutment that if you put them on there and you tighten it up, it'll sort of squeeze in there and hold things together. Okay? So that's sort of what the gist of that thing did. That was the connection between the implant and the teeth, and it was something that would take up the slop and allow it to be tightened up. Okay? So that guided abutment, again, you never find one of those again because after a while they found that these things come loose, everything wobbles, and then you can't replace it because you have to replace all of them, and it became a problem. But that was our second attempt at getting teeth immediately. So there's our little guided abutment. You can see it's got grippy rings on it. It's got a silicone sleeve so stuff won't get in there, and then it screws into the implant down below, holding the teeth in place. So again, we've got all missing teeth, implant placement, and then a final or temporary restoration. And I will tell you, 99% goes to a temporary restoration. I mean, if you make the final restoration, I was in a meeting once. They had somebody doing it in Japan, somebody doing it in LA, and somebody doing it in Italy. Simultaneous surgeries on big screens everywhere, watching it. And all 3 patients had their teeth when they were done, and none of them were happy. You know, it was like, you know, you'd expect them to jump up and down, right? They're like, you know, because the bottom line is that to get your teeth the way you want it, you got to live with it. You got to say, you have to have your wife say, your teeth are too yellow, or your teeth are too white, or they're too long, or too short. And if you go to the final restoration, when does that happen? That's all the dentist team figuring it out ahead of time. We're not that good that we can figure it out ahead of time, okay? So we can come close sometimes, and there's different types of patients. Some patients you can do anything and they'd be happy with it. But a lot of patients, you need the temporary to find out where your problems are, and then you can make it better, okay? So this is just an example of how the guide works, and this is how the drills go in. So you drill a hole in there with a twist drill, and those drills, they actually hold the guide in, so it's locked in their mouth, and then you drill right through the little holes with all your little drills, and even place the implant right through there. So once I got this set up, everybody in this room can walk into the operating room, and you can put that implant in, because all you need to do is shove everything in the hole, and it will just go exactly where it's supposed to go. Okay, so getting there is the problem, but once you're there, I've had cases that literally putting in 6 implants in an ideal situation took me like 12 minutes. You know, and I look around and go, honestly, that was it? But getting there was days of computer work and other stuff, you know, and then there was a little bit of little clinical know-how to go with it. But so that's the idea of the new guided surgery. And every company now makes a guided surgery. 3i, Straumann, you name it, they all make them. So what do we have as far as prosthetic options? The teeth in an hour, teeth in the day on the left, and the temporary on the right, something that's made out of acrylic or plastic. So what are we looking for? We want maximum patient comfort, minimally invasive flapless surgery. In the olden days, we used to get all the gum tissue out of the way, see where the bone is, put the implants in, cover it all up. Now we do it right through the gum tissue. If they have enough, then you don't even make a flap. You do every drill right through the gum tissue the whole way and put your implant in and you're ready to rock and roll. Faster treatment, and because of that, a lot less swelling and pain. Cost savings, that's sort of interesting because that goes both ways. And high anesthetics. So that's what we're trying to achieve with that. So here's a fixed full mouth case. And I showed you this one last year, but just it covers everything. So again, reviewing our panoramic x-ray, mandibles on the bottom, lower jaw. They have one lower molar over there on your right side. They have these lower teeth, and they have no upper teeth, okay? And that's not a lot of bone. If you were to measure this is like 2 and 3 millimeters. This is maybe 6 millimeters. My rule when I'm talking to patients is we want 10 millimeters of height and 4 millimeters of width, and we can get an implant in there without doing any grafting. So obviously here that wouldn't happen, there it wouldn't happen. And here we've got a nerve, the inferior alveolar nerve, that runs down here and runs down there. So again, that would be a little dicey too. So this patient in treatment planning, a conventional way, needed bone grafting in both sinuses, needed onlay bone grafting on both mandibular left and right side, and onlay grafting in the front. So she needed bone, so we got bone, and having a partner that's a plastic surgeon is good because he's good at getting bone. This is a hip, iliac crest, it's this area right there on your hip, which you can't see on me anymore, but on you guys you can probably see, it's right there. And that's where the little X is. And you make a little incision, and there's fat there. So no matter how skinny you are, you got fat there. And then you go through the fat, and you get a chunk of bone. And that chunk of bone would probably be about that big by about that big. Okay, so it's a nice sized chunk of bone. And then we're going to take that chunk of bone, and we're going to grind some of it up. We're going to get some more bone out of the hip and grind that up too. And we've got this grinder that weighs like 50 pounds. It's really cool. You put the bone in one side, and it grinds it up, and it comes out the other side. The assistants love that. That's their favorite job, the bone grinder. And it comes out looking like that. And then you sew up the hip, and although that doesn't look spectacular, the bottom line is that would be totally scarless. Okay, you wouldn't see anything when everything is done. And it's right in the bikini line, so you really don't see it anyway. And then you go inside the mouth, and we're going to make an incision all the way around. This is the roof of the mouth or the palate. And we've got our little pieces of bone, and we've got a little ruler up there showing you that, those are what the chunks look like. And then you basically take the chunks of bone, you lose little titanium screws, and you put it in place. And so you put it wherever you need it. And in this instance, we needed it on the lower left, lower right, upper left, upper right, and the front. So wherever there's screws, that's where bone was in. So at this point, we did a surgery to get the bone from the hip, transplant it to the upper jaw, and we sat for 4 months for it to heal. Okay, so now we're not at teeth in a day anymore, right? 4 months, and all we did was get it to heal, right? And we don't have any teeth, and we don't even have any implants. So that's where we are. And you can see the sinuses are very nicely grafted there. That's all that autogenous bone that was really ground up nicely. That's in both those sinuses there. So then the next phase was to get some implants in because our bone worked. So we got 3 implants there, 2 there. We were able to put those 4 implants in, but we weren't happy with the bone in the front, so we actually put a distractor in. And a distractor is just a technique of stretching bone, okay? And it was developed by a orthopedic surgeon in Russia, and he was treating dwarfism, and he was making cuts in the femur and putting this big apparatus there, and by turning, like we talked about last time, if you turn it 3 times a day, you move it 0.3 of a millimeter per turn, and you can actually get about 1 millimeter a day worth of growth in that area. So in this instance, we just distracted that and brought it down a little bit. And so then we're able to put more implants in. So when she was done, she actually has fixed teeth on her implants. So from this phase here, so put in those implants, wait 8 weeks. The distractor probably took about 90 days and some change to do its thing. Put in the additional implants another 8 weeks, so we're at 4, 6, 8, 10. We're probably at 12 months by the time that we get to see some teeth in there. Okay, now she obviously had teeth, removable teeth in there during the time, but nothing fixed like that. Okay, and so that's what we're looking at right there. So now, how about the all-on-4? What's going to be the difference there? This is going to be 4 implants, temporary restoration the same day. So you can come in with no teeth or ugly teeth. We're going to put in only 4 implants. There's a guy named Paulo Malo, cool name. He's down in Brazil, and Paulo Malo is the king of the all-on-4. He started it at about 2000, and with Dr. Brodemark's blessings, really took off with this thing. And it has a high success rate, and most importantly, it's a price point restoration, meaning that if we went out and we said, Don, how much is an all-on-4? I would say, well, my all-on-4 is $27,000, or if a prosthodontist does it, we charge $33,000. Okay, so that's sellable because that's all the people that are advertising, like Clear Choice and other companies like that. That's about where they're going to be. Okay, so that's a price point restoration like that, as opposed to this, which would probably be, when all was said and done, closer to $80,000 or $90,000. Okay, so there's a very big difference in that. Okay, So this is the guy starting right here. There's his teeth on day one. And there's his teeth on day one. And his teeth on day one. And there's his implants on day one. So got rid of all the teeth, put the implants in. And so 4 upper, 4 lower. He's going to have an upper all-on-4 and a lower all-on-4. We use a surgical guide. We didn't do it as a guided surgery. Those are the 4 implants with the holes where the teeth used to be on the lower jaw or mandible you're looking at right there. And what we did is we had a denture ready. So a regular old grandma kind of removable denture was ready to go. And that denture was then placed over these. So what you do is you say, I'm going to make some holes in the denture, and I'm going to, just like that, and I'm going to sit it over those little, what we call temporary abutments. And then what happens is, that same time, you'll go get a paintbrush and some acrylic, and you'll go ahead and put that acrylic on the temporary abutments there, and lock it in place. And then once you've done that, you're going to take all that off and sit in the lab and finish it up real nicely, and you're going to come up with that little thing. You'll end up getting a nice horseshoe that sits on 4 implants, and that's going to be their temporary restoration. It's screwed in place. It doesn't come in and out of the mouth, and that's what they'll wear. This person would wear out on his the day that we did the surgery. Okay, so the surgery probably took about 2.5 hours. Probably took 4 hours. It's upper and lower. Probably took 6 hours to get the uppers and lowers in temporarily, and then 3 to 4 months later, depending on the healing time, we would end up with a final restoration there. Okay, and the final restoration is going to be on a cast bar similar to that one. That's not his, but this is going to be a smile there, and that's what his upper and lower all-on-4s look like. So similar in appearance to a denture, but fixed in place. Has a titanium under substructure framework and acrylic on it with acrylic teeth. Okay, so you can see that's a better looking smile. This is a down view. You can see the 4 little holes. There's one there, one there, one there, and one over there, and that's what holds it in place. There's a little screw in each of those that attaches it to the implant, and that's the lower right there. Okay. So this is another guy. He was an all-on-4 on the lower, but he had some upper teeth that were pretty good. So rather than getting rid of those, he just got some additional implants. This is his final smile, looking handsome. There's his upper teeth, lower lower all-on-4. And you can see with the all-on-4 comes gum tissue. That's the pink acrylic stuff. And his own gum tissue is right down there. The upper is just all his gum tissue because those are just implants with teeth associated with them. That's a side view of him. And this is his little all-on-4 prosthetic. When it's out of the mouth, that's what it looks like right there. Okay? So it's a nice little titanium horseshoe. They used to do it in gold. Cost a fortune. Why did this become so popular? Because we didn't have to do that in cast gold anymore. We were able to mill titanium nowadays. So by milling titanium, all of a sudden, the lab fees on these restorations went from $14,000, $16,000 to $3,000 and $4,000. So it made it a much more palatable restoration for people to afford. And that's his other one right there. So that's what it looks like in the fingers right there. And this lady here, another all-on-4 case. Upper denture, so all that pink on top is not her. All that pink on top is denture teeth. Down below is the pink acrylic, and you can see that's supported on the 4 implants again. So another all-on-4 right there. Okay. So here's just some X-rays on this. So you can see my buddy Dr. Shoddy, he set up in Fresno when he was treating. They called it all-on-4, none-on-3. Because if you had 4 implants and they worked, that was great. But when one of them failed and you had 3, then you couldn't do the restoration. So we decided, most of the time with our patients, we'll do more implants. Like for instance, in the upper jaw where the bone isn't as good, we usually do 6 implants. And if there's a problem, then we still have the final restoration. They still have their teeth, and we don't have an issue. The lower jaw is a little more reliable, so 4 implants works pretty good. This is an upper and lower all-on-4 right there, and you can see just the radiographic. The key with the all-on-4 that was making it successful was being able to angle the implants. Right? That's not actually like we're doing it wrong. We're actually, the mental nerve right there is right there. So that major nerve leaves the bone and goes to the lip there. So we're trying to avoid the nerve. You can see it right there. And by angling the implants, it's like if you looked at a big crane. It has all that metal that's sort of angled there. Well, the engineers didn't do it because it looks good. They did it because it actually works better. Okay? So this one's had a lot of bone in the back, so the upper implants, all on 6 on lowers. And there's another one right there. All right? So basically, what we're dealing with here is the fact that nowadays we have the ability, because of computer programming, because of milling machines, to be able to go ahead and put in implants, seed a temporary restoration that's a denture that's adjusted, and have the patients leave the same day with teeth in their mouth. And because of that, what we're able to do now is what we're talking about: teeth in a day, teeth in an hour, teeth in a whatever, but all on 4 is now the new nomenclature that we use. Okay? So it's I guess the key with that is the advertising is what brings the patients, brings up the questions that the patients will have. Because they'll say to me, Don, you did an implant on me, you put the implant in, we waited 8 weeks, they put the crown on it, that wasn't teeth in a day. Okay? So what are they advertising? And this is exactly it. So when somebody asks you about it, now you understand. So I'll be done in a second here. There's another one right there, and more implants all over the place, but again, all on 4 on the lower, and that's it. So hopefully you'll get out of this that you'll start working on your skills as being an educator in whatever you're doing. The evolution of immediate load teeth and implants from novum, teeth in an hour, teeth in a day, to all on 4. Those 4 are the keys. And the amount of time it takes to complete complex full mouth implant cases, like the first one I showed you that actually was probably from start to finish, would probably be about a 1.5 year case, as opposed to just getting teeth the same day and or realistically getting that final restoration about 3 or 4 months later. Okay? So that's it. So thank you guys for coming. Any questions? You ready to go do that right now? No? Okay. Well, it is fun. So thank you very much. You guys have a great year. Hope everybody does fantastically academically and has a good time. So good seeing you guys again.
I have a question.
Oh, what's your question?
So what was the duration for all in 4 again?
Well, okay, great question.
Sorry.
So the realistic all-on-4 duration is you do the surgery and you have your temporary teeth in the same day.
Oh.
Okay? So you come in with ugly teeth and you leave with nice teeth. But you have temporary teeth at that time.
So
Usually the integration period, you go 8 weeks. So 2 months. And then the dentist or prosthodontist or whoever's doing the restorative will take the temporaries off, make impressions of everything, and make a new set that's going to be the final set. Okay? So if we went our fastest, it would be put the implants in, teeth the same day, 2 months later, impressions, and probably about 3 or 4 more visits in going over maybe a month or 2 before they get their final teeth. So realistically, most of the cases take about 4 months start to finish. Okay? As opposed to the other stuff that takes, way longer, obviously. So it's the price point restoration. If you said, I've got X amount of money and this is what my teeth look like, that's fine. If you said, yeah, I won the lotto, I wouldn't do an all-on-4 on you. Because an all-on-4 definitely isn't as good as the first lady we showed with the multiple implants. Because if there's problems with an all-on-4, and we have an implant that's lost, now we have an issue. The first lady that had, 12 implants or whatever, if you lose an implant, and things happen with implants, believe it or not, they don't all stick in there no matter what everybody tells you, then you still had one little thing you had to take care of. But the rest of the time, she was still chewing and eating and having a good time. Okay? Does that make sense? You're welcome. Yes?
I have 2 questions. The first was, what's the material difference between the temporaries and the permanent set? And then the second one was, in the procedure that you showed us, why use her hip bone rather than like porcine or bovine bone chips?
Yeah, good. Okay, great question. So I'll do this quickly so you won't have to stay too long. The material of the first one is acrylic. So just like a denture that grandma wears or a partial denture or a retainer that you had, that's acrylic. That's what the temporary teeth are on. The final ones now are usually milled titanium with acrylic or porcelain on them, or they could be done in milled zirconia. So I have a bunch of cases that are done in milled zirconia, which is the newest thing to do. Again, we'll see how new that is because I'm seeing a lot of chipping on those. It's supposed to be harder, but I'm seeing chipping. Okay, so that's it. Now, your next question, why the autogenous bone? Autogenous bone is still the gold standard for grafting. Okay, we have bone morphogenic protein, we have allografts, which is freeze-dried human bone, we have xenografts, which are bovine bone. But when it comes to really getting grafting to work in large areas, bringing in live bone-bearing cells is the best. Because everything else is dead that you put in there, and your body uses it as a scaffolding to grow into. That actually starts growing from day 1. Those are awesome questions. Yeah.
Thank you.
Yes?
Are there any dietary restrictions with implants?
Initially during the healing period, yeah. That's, again, they never tell you that. But yeah, if you did it all on 4, you'd be on a mechanical soft diet, like scrambled eggs, mashed potatoes, fish, stuff like that. Okay? You don't go eat ice cubes and almonds. Let's say that somebody lost a front tooth, and we took the tooth out, put the implant in, and put a temporary on it the same day. Again, no flossing around it, no brushing with an electric toothbrush like a Sonic Care. Do everything else everywhere else, but not on that one tooth. If we were just doing a single tooth, and you got to baby it for 8 weeks. At the end of 8 weeks, you could do whatever you want with it. Okay? Anything else? Great questions. All right. Well, thank you guys.
Well, thanks everybody. Hopefully it didn't bore you too much.
I'm always boring. My son says I'm boring all the time.
Anyway.
Oh, I like that. Oh, that's so sad.
Well, all right. You guys are welcome to stay and chat if you want. What's up? Oh, okay. Rahul has a couple announcements. Other than that, just remember the Facebook thing. Add us, and I'll accept it. And then Bonfire Friday. Yeah.
What's the group name again?
I think it's USC Pre-MLR Society.
Yep. Send it out in an email.
Thank you, Miss.
Wait, what's your name?
I'll tell you.
I'll look it up right now.
Hi guys, my name's Rahul. I'm your guys' community outreach director, and so our first Spread the Smile campaign, which is when we go to elementary schools to teach kids about dentistry and nutrition, health, and brushing and flossing, is actually this Friday, the 18th. We have 4 spots that can still be taken by people. They are empty, so it would be great if you guys started. You do need some SSCs for a lot of your service points to be in this group, so I would recommend getting on as soon as possible. And then on top of that, I was going to do a mandatory meeting for new members to get them involved. If you saw my little post on the Facebook page about, getting a little bit more acquainted with how to work with kids and how to use the equipment in a way that they don't get distracted by it. And so I'm thinking about doing that either Saturday, Sunday, or Monday. I have a poll, so for new members who aren't on the Facebook group right now, make sure you fill that out so I know which day to do it. And that's it.
All right. Thanks, guys. If you have any questions or want to stick around, welcome.
Who's got pizza on your way out?
Yeah, grab pizza on the way out.